Good evening, ladies and gentlemen. Welcome to the City of York Council Health and Adult Social Care Policy and Scrutiny Committee. This meeting is being webcast and it's Tuesday the 13th of April 2021. We have apologies from just the one councillor this evening. Councillor Perrott and Councillor Lomas is kindly substituting, and we have a full complement otherwise of the rest of the councillors. Do any members have any declarations of interest other than lodged generally? Not seeing any. No. Okay. Right, the minutes of the meeting on the 9th February are printed on pages 1 to 8 of the current agenda. Are members happy to agree that they are an accurate reflection of the meeting? Thank you very much. Thank you. We have two members of the public registered in public participation today. They're both wishing to speak on item 4, pages 9 to 12 in the agenda on A&E services at the hospital. Can you just remind me who's first lined up, please? Of the two speakers.
Sorry, the first is Gwen, Chair.
Right, okay. Gwen Vardigans will be speaking first. Thank you.
I'm speaking on behalf of York and Scarborough Defend Our NHS at the moment, opposing the plans for Vocare Limited to take over the minor injuries section of the York Trust A&E department. I've got 3 reasons for this. Firstly, the timing of these changes is inappropriate and insensitive. The staff at the hospital are desperately tired from balancing the care of patients with COVID-19 with patients seeking treatment at the A&E. Staff are also anxious about the prospect of a third wave of the pandemic as the winter approaches, and they feel undervalued by the abysmal 1% pay offer. And now they fear the loss of their work, particularly the highly skilled nurse practitioners. Secondly, the A&E staff seem accepting of the concept of urgent treatment centres, and I'm sure they are versatile and creative enough to meet the amended criteria for the UTCs, embracing the changes in referrals and appointments to minor injuries in addition to the unpredictable number of self-referrals that access A&E spontaneously. There are several different models of UTCs in A&E departments across the NHS, and they have been successfully adapted to the criteria changes without the involvement of a private company, let alone one like Vocare, which is a for-profit company. And that brings me to my final point and a question. We're informed that contracts awarded by the CCG are geared to specifications, budgets and costings that are determined nationally. Now, how are Vocare, a for-profit company, going to satisfy their shareholders that they will work within the parameters of the contract and still provide some profit for them? Will it be by cutting costs or reducing staff, diluting the skill mix, or perhaps reducing the time allowed for consultations, or by the dubious practice of cherry picking, which is adopted by some private providers when they're selecting types of treatment? My question is this: what does this committee feel that Vocare bring to what do this committee feel that Vocare bring to improving the care of patients in York presenting with minor injuries compared to the existing arrangements provided by the experienced staff of the local A&E? Is it worth the disruption and fragmentation of the service for what is quoted to be an interim solution? We know that the NHS works best as a coherent whole and as such outperforms private care in both quality and cost effectiveness. Local test and trace systems and the vaccination rollout is evidence of partnerships that work. I'm looking forward to listening to Agenda 4. Thank you.
Thank you very much, Gwen. We'll obviously be discussing what you've asked as part of the meeting. Thank you very much. So we have the second speaker, please.
Thank you. My name is Dr. Steve Crane, and I work as a consultant in A&E at York Hospital. Last month, I raised the concerns of our staff about Vocare, a wholly private and for-profit company, being allowed to extend its role in the management of the patients that attend York A&E. Frontline staff are opposed to this plan for several reasons, including fears that Vocare will be allowed to take over their employment contracts and that they will seek to take over other services such as minor injury management and the initial assessment of patients attending the A&E department. They're also concerned that the quality of care delivered by Vocare will ultimately suffer as they seek to make bigger profits by reducing costs in areas such as staff training and the time allowed for each consultation. The public of York have expressed their opposition to Vocare's involvement, with more than 14,000 people signing a petition opened by Rachel Maskell MP. And staff have also received messages of support from members of local trade unions, the York People's Assembly, and from others. In its update on urgent care centres, the Vale of York CCG has disappointingly confirmed that it has already been willing to commission Vocare to deliver NHS-funded services in York. I also note the reassurances given by the Hospital Trust and by Vocare that neither party has plans to transfer the front door streaming and triage process or the care of patients with minor injury to Vocare. These reassurances cannot be relied upon. York and Scarborough Teaching Hospital's NHS Trust has already transferred the responsibility for front door streaming of acute patients to Vocare at the Scarborough Hospital. In addition, according to its website, Totally PLC, which is the parent company of Vocare, has, and I quote, an ambitious management who have identified public market outsourced health services as an attractive prospect and have developed a plan to fully develop this opportunity, by which they mean an opportunity to make profit. Frankly, the idea that Vocare will be happy to limit their involvement in the care of patients in York is a delusion. The only way to ensure that private for-profit companies do not extend their influence in the care of urgent care patients in York is not to commission them to provide such services in the first place. I'm encouraged that the CCG consider the current contract with Vocare to be an interim arrangement and that it wishes to work with other local NHS providers in the delivery of urgent care services in the future. I think this is both a challenge and an opportunity to the new provider collaborative, and in particular to Nimbus Care, which represents local York NHS GPs. Nimbus Care has done a fantastic job in delivering the recent COVID vaccination programme. Now they need to work with others in the local collaborative, including ourselves in A&E, to provide a fully compliant UTC and primary care out of hours service in York, which is both NHS delivered and NHS provided. Wholly private for-profit companies like Vocare can only be stopped from making a profit out of NHS patients if local NHS teams such as Nimbus Care step in to deliver the services instead and are commissioned to do so. I hope that Nimbus Care and the commissioners will accept this challenge and be fully supported in providing a public NHS urgent care service by the City of York Council. Thank you very much.
Thank you very much for your contribution, Dr. Crane. And that brings us to the actual item 4, which starts on page 9 of the agenda. And I'd like to welcome Phil Metham and Stephanie Porter, who will be joining us for this particular item. The report's prepared by Stephanie Porter, who's the Executive Director of Primary Care and Population Health. And the item starts on page 9. Would you like to give a brief introduction, Stephanie, please, and Phil, as you wish?
Yes, so I'm Stephanie Porter. I'm leading the primary care team in the CCG. Thank you for the opportunity, and I'm picking up on Gwen and Stephen's point. The CCG has been working with a number of providers through a clinical reference group to look at the ways in which we can improve services, and we would include Vocare in that range of provider services. Because they have been commissioned and have been delivering a service for many years, at a point at which our GPs weren't in a position to offer urgent treatment centre services. So there's something about the evolution of providers and where we find ourselves now. So in terms of just referencing the agenda item, I think it's probably just helpful to be really clear about language. So accident and emergency services, blue light services, that's not what we're talking about here. We're talking about urgent care, where we have GP-led integrated minor illness and minor injuries services. So when we talk about Vocare as a provider, they offer GP services, and they're co-located at York Emergency Department, and they're there to help stream patients to get to the right professional, and that streaming service is through our emergency doctors employed by York Trust, and that will continue. I think you've heard reference, and certainly in the paper, we talk about a national standard for providing urgent treatment centres, and we're not compliant in York. So when we talk about interim, we have been looking at urgent care services for a couple of years now, extended because of the diversion of activity for the pandemic. But we have picked that up now, and we've got a technical piece of work around compliancy, which is what we've referenced as an interim solution. But we will be working with and continuing to work with all our providers, Nimbus Care, who are our GP group in the city of York, and we hope to continue to improve services so that we can respond to the details that we got when we asked our patients what they experienced from urgent care. So that's set out in the paper, and work continues. So I'm really pleased to hear that there's an acknowledgement that we are working together as a system, and we've got another agenda item about provider collaboratives, because our bit of the NHS is having another change, and it's a change that is meant to help and integrate both all our social care and health services. So we continue to work on that. And just finally, we have referenced that both the trust and ourselves have acknowledged that I don't know whether it was clunky language. I'm sure that's I don't wish that to underplay the strength of feeling that we've heard, and we've met with interested parties, but there was never an intention to transfer staff or the employment of staff into Vocare. So yes, both the trust and Vocare will continue to deliver the service to establish joint governance arrangements. So I'll just pause there and ask Phil if he wants to add anything.
Thanks, Steph. Colleagues, I'll not add anything, but just be available for questions, other than just to clarify the point that Steph's already made, but directly responds to the first question, which is to say that Vocare as a provider have been operating within the York system for some years now. So this is not something that is new and or introduced in terms of a new provider. I think, Steph, 2015 rings a bell with me. So Vocare have been working collaboratively within York Trust for a period of 6 years already. So they are not new in that sense. Just to clarify that, which I think responds directly to the first question, which may have implied that they would be a new provider. But I'll add nothing else. Thank you, Chair.
Thank you very much, Phil and Stephanie, to both of you, and for coming along this evening. Before I open up to to members for questions. It strikes me that I think part of the public perception, I think, is possibly the organisation's not a recognised name, and it's a generic brand name, a bit like, you know, Circle or Interserve. And I just wonder whether it would have been more helpful to describe them as providers, as groups of, I don't know whether groups of GPs is the right term, but that might have reduced some of the anxiety that perhaps people might have about any perceived change. And of course, GPs themselves have always been independent of the NHS, even though people use them through the NHS. And I just wonder whether that point perhaps hasn't been conveyed across too well in a communication. I don't know what your thoughts are on that.
I'm not really sure, Chair, about that. They are a private company. We went out to an open procurement, as Phil says, in 2015. We followed due process as it was determined then. Colleagues might be interested to reference in the white paper that procurement will change. So something we will see a shift from a competitive environment into what we're going to hear about, the provider collaborative. So in that sense, the professionals that make up Vocare, we commission a GP-led service for minor injuries and minor ailments, but every patient who walks through the emergency department is triaged, assessed by staff from the emergency department, and then they are streamed away from A&E in that language into this walk-in service, or patients from York can be directly booked if they ring 111 into that service. But Vocare are what they are. There's no plans to change the way in which we increase the funding to that service. Part of the clinical reference group is around how we give patient choice about accessing urgent care, and we'll continue to keep that dialogue going.
Okay, thank you. Thanks very much. So we'll go to members' questions. Councillor Taylor first, please.
Thanks, Chair. I note that Vocare have been involved in service provision since before this is, if you like, come into the spotlight. I mean, that's still a problem as far as I'm concerned. I mean, private involvement in the provision of public health care amounts to our tax leaking out of the system into shareholders' pockets further down the line. But can I just get clarity in one of the other things you mentioned, which is, are you basically saying that after this interim period, unless there's a substantial or significant change, you could imagine Vocare continuing what they're doing at the moment or doing something else? It's not like they're just going to disappear, is it, after 2022?
What we'd expect to happen would be the three primary providers of service, York and Scarborough, Vocare, potentially Nimbus, to work in that space which we're describing as a provider collaborative, to address both the national compliance issues, but also the things that we've heard from our citizens and our patients, which is actually for urgent care, those who are residents in York, ideally they'd like to see their own GP. So we're wanting to work through how there can be a system change that is not destabilizing, but is part of addressing the multiple range of issues that we have to address. And we see that change as part of the provider collaborative. if we hadn't have had the pandemic and pre the white paper, when the contracting came to an end, you know, a year ago, we might have been having a slightly different conversation. We might have gone into a commissioning, a re-procurement contracting cycle where we spoke to providers, or we went out to the open market with a specification, with a value. And that might have been the arena that we were in sort of 12, 16 months ago. But that's not the case now. And I can't, I actually think what we're moving forward in is where providers and clinicians in that space determine an end-to-end service change that is to the benefit of the system, that's safe and sustainable.
Thank you, Stephanie.
Is that a yes?
They'll certainly be there in the early phases, and I'm not going to preclude what those providers will arrive at, which is the right solution for providers and citizens and patients.
Thank you. Phil wants to come in there. Phil.
Yeah, thank you. Just to respond as well to Councillor Taylor's question, which is a good question. It gets right to the heart of it. It's probably worth just reflecting a bit on recent history. So part of the role of the CCG is in bringing about improvements to services for local people. We engage local people and ask them what they like to see. And the people of York have said to us over the last year, as have local clinicians, they'd like to see more involvement of general practice in the delivery of urgent care that currently you would get in York Hospital at the front door. So more of a primary care led model is what we'd heard. So we respect that, absolutely, of course. But the interesting related issues are in and around 2015, GPs opted out of an involvement in that sort of care as part of their national contract. And so although there are some GP practices that may be interested 6 or 7 years on in providing some sort of care in that way, things have changed over recent years, and it's complicated by so Vocare are sort of covering what the GPs used to do in some way, particularly out of hours. So the question is, do we have enough GPs? Are GPs now interested in carrying out some of that work when we know they are already really stretched? So that's, you know, an interesting question for us within the city. How would you want to prioritise that GP time? And one of the complications that we've got, just worth thinking about, is the GPs currently provide their services against a patient list. So if you're on a GP practice list, you go and see the GPs that work there, and that's how the contract mechanism works. For us to be able to carry out a transformation of urgent care services that would be more primary care led, it would need to be open to anybody who accesses services in York, including visitors. And that's a real change and a real difference. So if you require urgent care and you're a visitor to the city, you walk into the hospital, access services in that way, and there may be at some point a Vocare input to that, and it could be a York GP that is doing some work there on a contracted basis. For our GPs to take on contractual responsibility for this in the future, which responds to the requests of some people in York, it would require a significant change to not only how services are provided, but how we contract for that, which is a significant shift for general practice and primary care. And remember, in 2015, they opted out of a narrower slice of that. And 6-7 years on the back of a pandemic, our capacity in primary care and general practice is more stretched than it was in 2015 when GPs opted out. So as Steph's indicated, there's a balance we require in here of providers who are able to offer a service that meets the needs not only of our registered patients that live within the city, but also our visitors to the city. And what we're trying to balance in all of this is a way of ensuring that can be met whilst also recognising some of the national standards that are upon us to comply with, we currently can't meet. And so making a shift may make that even more difficult on the back of the pandemic and a very stretched workforce that we have at the moment. So it is quite a complex picture, and the work that the CCG has done, as always, has at its very heart listening to what local people tell us and listening to what local clinicians think is reasonable and achievable. And that's captured in Steph's paper. Our role in this is to facilitate the will of clinicians and local patients, whilst recognising, as indicated in the questions, that we have to spend taxpayers' money within a set budget. And so that's the balance that we're trying to achieve here. Thank you.
Thank you very much, Phil. Councillor Lomas and Councillor Heaton, please.
Thank you, Chair. I just wanted to pick up a couple of points. It was interesting, Phil, what you said about listening to what local patients are saying, and you said they are saying that they want local GP involvement in provision of these services. And I'd be interested to find out what the question was that was asked and exactly what the answer was that was given, because it strikes me that what most of the residents that I speak to talk about is wanting a more human response. And if they see a GP as more of a human approach than a corporate approach, then perhaps that's why they're saying, yes, I want the local GP, not a corporate response on this. And I think that what people actually want is an approach that will be not about saving money and not about doing things in the cheapest possible pilot high and sell it cheap kind of way, and not to make profit for private companies, but actually a more human approach to the care that they need. And perhaps their perception is that a local GP would offer that, as opposed to a larger, more faceless organisation. I also just wanted to pick up on, Stephanie, you seem to suggest, and I may have misunderstood what you'd said, but you seem to suggest that the providers would be shaping what is provided in future, and that seems a little odd to me, because that seems to say that the people who are currently making money out of this, and we are talking about a private company who are making a profit from what the taxpayers' money that is going in to provide these services, that they would shape what service they choose essentially to provide in the future, and therefore what is best for them to make money on. And I think that comes back to, one of the public speakers mentioned cherry picking, and we certainly see that in other areas of health commissioning, where companies will cherry pick services where they are most likely to make most profit because they can deliver them at cheapest cost. And inevitably, we've seen that means poor wages for staff, and poor working conditions and poor care for the patients. So that would be a concern for me. And I think that, Phil, earlier in what you said, you talked about essentially that the GPs opted out of providing this kind of service, 6 years ago, and therefore, because they've not done it for 6 years, they wouldn't be able to be involved in it now. But surely there must be a way to engage and involve them in thinking about how they might contribute to urgent care provision, in it perhaps using a slightly different model. So rather than going for one provider who can do it all, looking at different elements of provision and how you can meet the needs of local patients and of those visitors that you mentioned, who might access treatment through A&E rather than their local GP. So it just seems to me that at the moment this is being presented as something which is interim, but actually in a way that shapes what is going to be provided in the future on the basis of those people who have been allowed to undertake the work so far.
So I can come in and answer a couple of those points, if I may. So the first thing about providers being involved. So we set up a clinical reference group that involved all of the clinicians so that they could have that conversation, and they're best placed to understand how things work now. When we talk about local GPs, under the umbrella of Nimbus, they are in that conversation. So we do see this as a maturing approach to thinking about what the service requires. And we put clinicians at the forefront of that. And that's the bit that's about the way in which the service will change and adapt over the long term. So you've got this change program happening and has been happening, and then overlaid over part of it was a compliance issue which our NHS England regional colleagues wanted addressing. And the way in which that compliance issue is addressed is with the current providers who are non-compliant, so the Trust and Vocare. So when we talk about that being interim, what we want to ensure as the commissioners of the service is that anything that happens to achieve that compliance isn't hardwired into the service that would prevent the service change happening and continuing. So I hope that clarifies that point.
Can I just ask a little question about what you've just said? Is there a difference between, you talked about just then about clinicians, is there a difference between clinicians and a provider? Because to me, clinicians is people who, the actual people who are delivering the service, and the provider might be the company which employs them.
So our clinical reference group is the frontline deliverers of care. So they've been involved, and we, I don't know when Dr. Lee came, we made a conscious effort when we were talking about service redesign to keep, shall we call anybody else who's a non-clinician out of the first 3 workshops. So anybody who is a manager or a contracts manager or performance manager, so that clinicians could work through what that looked like. So when I talk about clinicians, I'm talking about those that are hands-on, but ultimately we do have to identify how we move forward on a compliant service, because what we haven't necessarily talked about here is the technical elements of how somebody rings NHS 111 and how the computer system links to the appointment system, so you can have a direct booking into that minor illness as opposed to arriving on foot. So there's a lot of sort of technical things sat behind, and the way in which urgent care will change as we move forward. I want to just also talk about that, the theme about local people wanting to see a local GP. And I think there's two elements of that. We do know that some of our local GPs are contracted by Vocare, but actually in the urgent care sort of service delivery, you might see a York GP, but it might not be a York GP that is the practice that you're registered with. So we're trying to balance that centralized model. And what we've said is that this interim solution around compliance just needs to make sure that we continue to work through and address the issues that we heard our patients tell us were key things that they wanted addressed. I wish I could remember all the questions. I can't. But what I can tell you is that the strong themes that came forward from our residents, our patients, were, in an ideal world, they'd like to see a local clinician. And secondly, they were really confused about all the different ways in which you accessed urgent care or something that wasn't routine care. They were confused. So that and they're really simple themes, but they're quite complex to make sure that as you change, you maintain a safe service. So what we've asked providers to do over, not limited to having to do it within a 3-year period, but giving themselves a safe period of time to respond to those things. And clinicians are, for our mind, are at the forefront of that.
Thank you, Stephanie. Councillor Heaton, please.
Thanks very much. Just a couple from me at this point. I mean, Phil, you mentioned the GPs opting out in 2015. What were the reasons given at that time for that decision?
Thanks, Councillor. I can't speak on their behalf, so this is my subjective assessment. So at that stage, across the country, GPs were finding their services reaching a point at which they were becoming too stretched for individual GPs and for their practices. And so the decisions that were made with a consultation with the local medical committees that represent GP practices was that for the next phase of the NHS, they would not have those services part of their contractual service. When that decision was made in York in 2015, I wasn't working in York then, but the practices in the city worked more independently than they do now, and so the Nimbus label that you've heard relates to how the practices in the city are now working as a collective, so working as one provider where they think it is right and appropriate. That's a real step forward, and it gives them scale opportunities that they've not had before and addresses some of those historic and current concerns. So Nimbus as a provider vehicle is interested in how it can contribute to a transformation in the future delivery of services like this. And the CCG is encouraging it to think about that and involve itself in direct conversations with other providers. We would absolutely encourage that, and we will see where that goes. As mentioned earlier, there are complicated contractual issues here, as well as difficult issues of prioritization of clinical time across end-to-end pathways. But as a CCG, we would absolutely endorse and encourage the clinicians, our GPs who are part of Nimbus, being involved in conversations about a future model which would respond to the requests and wishes of our patients.
Thank you. So it sounds like what we've got in a significant way is a capacity issue then, that's a serious underlying factor. And I believe from comments we've had and what we've seen, that's likely to remain. Would I be correct in thinking that? So,
Steph, you'll have a better answer to that than me, but I'll give a poor one first. So a generalisation is that in the City of York, we enjoy a quality of general practice that is the envy of many other parts of the north of England. So let's start there. However, the last 18 months has made it the most difficult time for general practice across the country, and possibly more so in the north of England. And our GPs are saying to us that the demand for their services is placing pressures upon them and their staff, which are unprecedented. So is it a capacity question? Yes. But it's a capacity question that applies across all of the country. We were and we are still in a position which is the envy of many other parts of the region. However, does that mean this is feasible and achievable in a way that we would desire? I think we have to see how we go through the next 18 months or so. But that's my manager's subjective assessment, not the assessment of an experienced professional like a GP that we would have in the city.
Thank you. Did you have anything you wanted to add to that, Stephanie?
Yeah, so I think it goes to our broader conversation about right skills in the right place. So we've talked about GPs, haven't we? But actually in our surgeries, there's a much broader range of skills, and it fits into that jigsaw, which is, some patients are already getting same day care, which we might in some respects deem urgent care when it's sort of 9 a.m. to 5:30, for example. And there will be GPs who want to do long-term conditions, have that sort of continuity of care with their patients, as well as some GPs and other professionals who would like to do the urgent sort of same day work. So I think whilst we have a conversation and we focus on GPs, there is a much broader picture going on with our citizens, particularly prompted by telephone triage, which I know isn't everybody's cup of tea, but we are sort of using technology to support and supplement the workforce to try and get people to see the right person with the right set of skills for their needs, and GPs are part of that. But I would just want to also, just put a shout out for a really fantastic range of additional professionals who can work alongside consultants, GP consultants who are part of that solution as well.
Thank you. Yes, it does sound like we've got a lot of the national concern there. If I may, one more, Chair, just very quickly.
Yes, go ahead.
Thank you.
That's right.
So just turning to another side slightly. So it's noted, and we've spoken that there's currently no plans for staff to be transferred to Vocare under these plans, which I'm inclined to take in good faith. But we have heard about other shifts. Is there anything in place that would guarantee that this wouldn't happen, even in potentially unforeseen circumstances, that can give staff greater peace of mind?
I don't know that we can. We're not employer of those staff, but it's not our intention to specify anything of that nature at all. And in fact, like you, we take the assurance that we've been given in writing by those organisations that was never their intention either.
So it's in writing in there, certainly. So, okay, thank you very much.
Thank you, Stephanie, and to Councillor Heaton for the questions. Councillor Taylor next, please.
Thanks, Chair. Councillor Heaton's sort of covered one of mine, and it was an important one. Around the whole idea of the GPs opting out a few years ago. We need to know why, because I'm sure there's many cases across the health ecosystem where opportunities arise and the sort of more public provider option just won't be in a properly supported and funded position to meet the requirements of those opportunities. And it is a concern, and in a way I feel for yourself, Stephanie and Phil. I don't mean to patronise you, but the NHS being the NHS means that you've got representatives like yourselves all over the country trying to make the best of a national car crash and a deliberate starving of the NHS. And the white paper's coming through. There's some good stuff in that, and we're going to talk about that in the next item, I'm sure. But one of the things it doesn't deal with, despite everything you've said here, despite what everyone's been saying for years now, is the workforce problem that we have. And until we're recruiting and training more, medical professionals, GPs, nurses, whatever, decisions are going to be compromised. And that blame lies squarely with the government. And that needs to be raised here, because it's not just you two sitting there scheming. I'm not saying you are scheming, by the way, but there's a bigger picture, and that needs raising here. I know I word things cruelly, but it needs raising. But my questions are, first one, given what I've just said, and given people's concerns around, potentially being redeployed under another organisation or whatever, and I accept that there's no plans to do that at the moment, and nobody really intends for that to happen, but circumstances dictate decisions, and the government doesn't get its act together on the NHS. And we keep having opportunities for services and contracts that come up, and the private element of healthcare provision gets stronger and stronger and stronger, and the public element gets weaker and weaker and weaker. We are going to have a situation where the likes of Vocare and all the other organisations that come under Totally PLC acquire more and more of what's done on the ground. So I don't think a proper reassurance can be given to staff that in time they might end up in an awkward position where they might have to go under a company like Vocare. And if you want to come back to that, I don't know if it's a question or a statement, but I can see why the staff are concerned, because I can see how this goes.
Thanks, Councillor Taylor. It does sound more like a statement, I think. But if Stephanie and Phil want to say anything in response, please do.
Thanks, Chair. I do have one more question after that.
Okay.
I'm not sure there's a an answer directly to that. I recognise what you say, but I don't think we're in a position to respond with any authority to that, other than to say that we're not we're not scheming, and everything that we do is absolutely open, transparent, and in collaboration with other organisations, local people, and clinicians. But happy to take a final question.
Yeah, thank you, and I appreciate that. I mean, you've got to work with what you're given and the sort of national requirements around what you're given, and sadly, I can't see that changing significantly anytime soon. But one potentially tangible improvement that we might be able to look at locally, when it comes to concerns around private involvement in healthcare, is that when we do the resident engagement that's been cited, I think mainly by yourself, Stephanie, where you're saying that residents and patients want this, that, or the other. Whenever I've seen that type of consultation, I've never seen a question that sort of says something like, and would you mind if this was provided by a company which will use your tax to line their shareholders' pockets? And I'm sure a more diplomatic question could be formed, but when we're asking people about the types of healthcare they'd like to receive and how they receive it, I do think we're now at the stage of the NHS, sadly, where we're going to have to put that question in front of people to say, okay, you've said you like this more than you like that, but if we say to you that that option is provided by a company that will take tax out of the system for their own means, does that change your opinion? Can we start asking that type of question in the engagement we put out? And as I say, there's always more diplomatic ways of wording it, especially when I'm trying to put sentences together. Blimey.
We could ask those questions. I don't know that we'd have the wherewithal to do anything with the answer. But what I would say on a broader question is that, not for the topic of conversation UTCs, but we do often put a choice to patients about where do they want to be seen. It's not associated with a tax increase or any sort of notion of hypothecated values from the Treasury, but you've piqued my interest in what questions we might want to raise when we engage, and in the context of how we'll work with the council and your participation officers and our engagement officers. I'll give your prompt some more thought.
Thank you, and Chair, if I may just to sort of clarify why I asked that. It's not to sort of get all grandiose and theoretical. It's more when we ask people about the healthcare they like to receive, it's always very much on that initial, what is your direct experience like on the day? What would you like that to look like? And I think that's probably why we don't get into the background of where the money's going. But over the course of many years, and when you multiply that over the course of the size of the country, it is a direct impact if services are being provided more by private firms than otherwise, and that then would impact on future services because money is going out of the system. So that's where I'm coming from. I mean, as I say, very rough, sadly, because I need to basically get better at how I put things, I think. But I think you see where I'm coming from, and I appreciate everyone giving me the time.
Thank you, Councillor Taylor. I don't see any more indications, unless there's one final important question that any member would have. I think we'll move on to the next item. No, okay, right. So we'll move on to agenda item 5. So that's plans for the future of the health and care system in York, and linked with the York Health and Care Alliance. And in the agenda, it's pages 13 to 48. joining us for this particular item. I'd like to obviously Phil and Stephanie are staying with us for this. I appreciate, Phil, you might need to leave before we get through this, so please do when you need to go. We appreciate you joining us this evening, so just go when you need to. But joining us also, we have Sharon Stoltz, the Director of Public Health, Peter Roderick, who's the Commissioning Officer who works across CYC and the CCG, and Councillor Runciman, who's of course our Executive Member for Health and the Chair of the Health and Wellbeing Board. Hello and welcome, everyone. Shan, were you going to give an introduction on this one?
Yes, I will do. Thank you. Thank you, Chair. I accept that you've had a report in your agenda pack today, together with the appendix, which is the Concord for the York Health and Care System Alliance, which gives a little bit more detail of the actual governance arrangements of the alliance. But I thought it would be helpful if Peter Roderick, joint consultant in public health across the council and the CCG, shared a presentation with you, which puts the report in context, and Peter and I can also update on developments since this report was written. So I'll hand over to Peter.
Thank you, Sharon.
Thanks, Sharon. And good evening, councillors. Let me share my screen. Oh, I don't think I can at the moment. I don't know if one of the technical team can help with me sharing my screen.
You should be able to do that now, Peter.
Fantastic. Thanks very much. So I hope people can see the presentation, future plans for the health and care system for York. Can somebody just give me a hand up to say if they can see it? Fantastic, thank you very much. Okay, so I'm going to talk through just a few slides. I guess the first is to paint a bit of the context around some of the work that has happened over the last year in particular, though obviously longer than that, that I guess might come under the banner of collaboration in the health and care system in York. And I think, the pandemic has had, terrible effects on various bits of our society. But one thing it has done for the health and social care system has probably enabled us to accelerate work to join things up quicker, and some of the barriers that we've had before to do so have been taken down. We did some work at Vale of York CCG probably around a year ago now, or maybe around June last year, to try and understand with our clinicians what was happening within the health and care system. And one local clinician commented that, at times we were doing types of projects and work to bring services together that might have taken 3 years and taking 3 weeks to do so because of the need to work together to tackle COVID. So some illustrations of what that looks like on the slide in front of you. A lot of work around discharge from the hospital, rapid discharge, and bringing new beds online in the system to help people's recovery, work on avoiding emissions and better support for people in the community, work like the pulse oximeter program, where we give people oxygen saturation monitors in the community now to spot any deterioration in their symptoms if they have COVID. A COVID hub in the third sector, which was actively calling anyone with a diagnosis and a positive test and supporting them, safety netting them to try and see if any deterioration had happened, which is wholly staffed by volunteers but working in conjunction with healthcare. All the work that's been done around outbreak management in the multiple settings. We've had outbreaks in PPE, understanding what the capacity is in bits of the system and moving patients as and when that's been required. And of course, vaccination and the mobilisation of a fantastic vaccination program in 4 or so months, getting through over 100,000 York residents. It really has been quite amazing how quickly that has worked. And so if that's the context of the last year and how it's felt sometimes in the system, another key piece of context is this white paper, which has been referenced already in our meeting today, I think, but just this is a summary of the key points on one slide of what that white paper says. It was a paper published in February, and its changes are going to come into effect for April 22, with the legislation that will be necessary, probably going through Parliament over the summer. And what essentially it does is to recognise that the what are called integrated care systems, these regional bodies that have been in place for a few years, and our local one, Humber, Coast and Vale, has been formally an ICS now for over a year. Those systems are now going to become statutory organisations. Previously, they've been tasked with partnership working across boundaries, across local authority areas or across hospital trust catchment areas, but they haven't had any formal status. And as of April next year, integrated care systems, ICSs, are going to be statutory bodies, and they will take on the statutory and the funding commitments that clinical commissioning groups have. So at the moment, we have 6 clinical commissioning groups that are in the Humber, Coast and Vale area. As of April 22, those CCGs will not exist anymore, and the ICS will take on many of their statutory duties and many of the responsibilities they have to allocate money. And I emphasize this is about what we call commissioning in the most part, or the contracting and the paying for services in the NHS. So this is in some ways a change which does affect providers and the services that people will receive, but not immediately from April 22. And it's not that from April 22 next year, there is a sudden revolution in the way that GP services, hospital services, etc. will be provided on day one. This is very much at the level of the system within our region and the way decisions are taken primarily, though of course we hope it will improve the way services are provided. And there is this duty to collaborate, which is upon not only the health service, but now upon local authorities as well. So a duty to collaborate in these new systems together, and in fact, as part of their governance, the ICS needs to have local authority representative sitting on it. And because ICSs are large, and Humber, Coast and Vale is a large area, it has 1.7 million people in, there's also a lot of emphasis on what they call place. So whereas we used to have a Vale of York geography with York plus Selby plus Helmsley, Pickering and some areas north of York, the geography that most decisions are going to be taken at within the ICS is going to be local authority geography across all areas. So for us, York will be taking many of the decisions that Vale of York CCG has hitherto taken, but on a York footprint, which actually for us, I'm sure partners around the table will recognise, actually works well when we have a council on that footprint. Our GP partners work increasingly on a York City footprint. Our schools and academies work on that footprint. Our voluntary and community sector thinks on a York footprint, and that sense of place is actually quite clear within the guidance that the government is setting out. So our response has been to realise that we need some sort of vehicle to be able to receive some of the decision-making functions, possibly some of the budget that goes with this new structure within the NHS. And we've put forward the plan and the proposal to create a health and care alliance to strengthen the partnership working within the system, to have enough of a robust governance to replace some aspects of the CCG. For instance, when the CCG receives money, it obviously has a number of governance and financial mechanisms to govern that money and to allocate it. Nothing currently sitting in the system aside from the CCG at the moment in York would have that sort of function, and the alliance gives us the potential to do that. And the alliance itself, because we need to grow the relationships around the table and to work on how the alliance will work together and what it wants to do, how it wants to keep some of the decisions at a local level. The proposal is that that alliance actually exists in shadow form this coming year, and in fact has its first official meeting in a couple of weeks' time in April, and then meets monthly across 21-22, so that when we come to April next year, we're ready and we know what we're being asked to govern and what we're being asked to do as a system, and we have those partnerships in place. This slide just runs through the membership of the Alliance as we have it at the moment. And as you can see, the CCG, as it currently exists, has a seat. The hospital and the Mental Health Trust, which covers our area. The primary care services provider, Nimbus Care. The council, the CVS within the city, St Leonard's Hospice, the York Schools Academies Board, and then primary care networks have nominated 2 representatives from the GP community directly. So that's not the primary care services that Nimbus provide, but for overall GP services. And the aims of the Alliance are on this slide. We have held a series of workshops and agreed some overall aims for the work we want to do to make them people-centred, to make our services more integrated, and to give timely and appropriate care. And people can read more about some of these aims and some of the objectives within the paper that's in the meeting pack. On this page, we have tried to represent some of the things we think are unique about York's health position, and some of the, I guess, a platform for the change that we want to see. So York is sometimes seen as a very affluent city with very good health, and in the main part, we are lucky. We do have affluence, and we do have overall generally better health outcomes, but not in all areas, and not in all areas of the city. And we have a number of absolute needs, which, whether you compare us to any other area, are causing preventable harm every year. So 1 in 10 people smoking, 2 in 3 adults who are overweight and obese, 1 in 7 of us living with a common mental health conditions such as depression. We have a widening gap in healthy life expectancy. We have a number of red flag areas where, compared to other areas, we don't do so well in health outcomes. So our alcohol consumption and emissions data, data on our mental health of our citizens, and our self-harm and suicide data, our student health are particular areas where we want to focus and know we have a need. We have changing demographics and an aging population, and a population with more ill health in it. And of course, we have some economic factors related to COVID, which we know may cause ill health in the future. We've tried to align the outcomes that we want with the joint health and wellbeing strategy, and try to be very clear that the start well, live well, age well, and the mental health priorities that members of the Health and Wellbeing Board have written are key to the work we want to do, and really are our overarching umbrella for the work we're doing. And out of that, we've defined some areas of focus, some areas of which partners have said, actually, we think we can work on this together over the next year. It's tangible. It works on. It works in terms of inequalities and narrowing the gap in our population. And it's work where lots of partners are involved in dealing with those population health needs. So diabetes, meeting the needs of people with learning disabilities and autism, people with complex care, which require joint packages of care between council and health. And this final slide just talks a little bit about the governance. So we have taken the proposal for how this alliance will be governed through first council executive and then full council, which was approved in March. The alliance won't be a legal body in this shadow year, can't require any partner to act in any way, and essentially decisions it takes about partnership working it wants to do will then be taken back into organisations to be approved through the organisation's governance mechanisms that they have. And it's been decided that the best way for this to happen, particularly from a council perspective, but also from a partnership perspective, is if the alliance is a subcommittee of the Health and Wellbeing Board during the shadow year. And we will look to review the governance as we go along to see where we've got to across this year. It's been proposed that the alliance chair will be the leader of the council, and we're going to present further reports to council, and very happy to do so as well to Health Scrutiny Committee, to update on the progress of this work, as we recognise that it's a key piece of work. And in some ways, we are learning how we're going to do this work together, and some of it isn't fully set in stone. So we want to make sure people are involved, included, and we get the process right on this. So, Chair, I'm finished there. I'll stop sharing my screen and hand back to you.
Thank you very much, Peter. Before I open it up to members, and I guess this is a question for any of our health professional colleagues, I think absolutely, and I'm referring to paragraph 5 on page 15, but there are elements within what you've just shared there, Peter, about potential achievements and aims and objectives. And I think absolutely support the principle of what's being proposed. But are you able to give a few examples, perhaps with some specifics, about what services we're likely to see that will have an increase in quality, and perhaps some that might return a cost saving as well?
Yeah, I absolutely can, Councillor Doughty. The cost saving element might be fairly difficult to judge at this stage. And I think I would frame it in terms of the opportunity cost. So when we do have that fixed envelope of money to spend for the citizens of York, for me, I think it's about the value, and that word is often used within healthcare, that we try to meet the needs of people to the greatest extent we can with the costs of money that we have. And if we're paying for poor quality or poor value care in one area, it means that some are losing out in another area. And I think that is the aim of much of what the CCG has tried to do across the years, and bodies such as NICE, the National Institute for Healthcare Excellence. So that is, I think, inbuilt into the process that we're trying to do to try and produce value from services. But it will be hard to exactly quantify that right now about the work of the Alliance. But I can point to the Alliance's work that we intend to do on diabetes and on learning disabilities. So diabetes has a particular focus. We know that there is a national programme to prevent people from developing diabetes if they have blood sugar levels that are in the level just below when a diagnosis takes place. So technically it's a 48 millimoles per litre of blood, and if you were in 42 to 47, you are pre-diabetic, and there is a programme which is offered to help you maintain a healthy BMI and to take physical activity and to keep your types of food that you're consuming in the right areas so that your chances of developing diabetes are better. And targeting the right bits of the York population to get into that scheme, which is a free NHS national programme, has proved quite difficult, sometimes because the way people are identified diabetes is split between different organisations, and sometimes because people just simply don't come forward to their GP when they don't have any symptoms of a problem. But actually, it may be that many of the areas of work that public health lead on through our health checks programme, or other areas of work in terms of voluntary and community sectors, would encourage people to go and get those levels checked out. So that might be a real tangible of where we can identify people who are at risk and actually of getting a disease which probably costs the NHS more than any other single condition, diabetes, and prevent that. And actually that might lead to a cost saving in the long term. So that's a piece of work that we've identified, the diabetes prevention programme, that we want to see as part of this. And learning disabilities, for me, I think there's a lot going on in to support people living with a learning disability in York, and a lot of fabulous work, but also quite a lot of unmet need, often diagnoses which happen too late, and waiting lists which are too long. And the work that we're proposing to do is to be able to share the data that general practice has with the data that social care has, which hasn't been possible to do because of historic problems with data sharing, often between health and social care, and being able to see that patient level data when a GP can see in front of them what information social care has on their particular patient. That's been a very hard thing to achieve. It won't happen overnight, but part of this work has been about identifying people living with a learning disability better for general practice so they can get some support. So just, I guess, two tangible examples of the work that we want to look at in the first year, but I think we're very much at the beginning of the process, and there will be many more. I think the aim is, and the difficulty is, to be tangible, to make sure that this doesn't become another set of, it doesn't become just rhetoric, it has real sort of things behind it. However, until we've started collaborating more, we've not yet identified all the work we're going to want to do, and we want it to be shaped by the citizens of York and have actually quite quite a lot of aspiration for the Alliance to engage with citizens and patients through current patient engagement routes to try and get their views on what needs to be improved. So wouldn't want to preempt some of those discussions as well.
Thank you very much, Peter. Right, members' questions. We'll start with Councillor Culloch, followed by Councillor Taylor and Hook.
Thank you, Chair. There's so much about this that I welcome, and it's so encouraging that the experience of these last months has helped to bring about this integration of health and social care. And as I say, that has to be welcomed, but I can't help but have some questions and anxieties, if I'm honest. Two in particular, so I'll mention both if you'll permit me, Chair. The first is really around accountability. And of course, at this point in time, this very committee has a specific role in terms of scrutiny and accountability on behalf of the people of York. And I really welcome the emphasis on place. We recognise that one of the great difficulties over the past experience has been that our boundaries are not shared, and services are not delivered within the same localities with the same responsibilities by different bodies. So that all of that is good, but I'd really love to hear more about accountability in a local context. That would be much appreciated. The second is, again, just looking for reassurance around data sharing and security of that data. So if you could give me some reassurances on both of those, I would be very grateful.
Yeah, I'll be very happy to, Councillor Culloch.
I was going to say, Peter, do you want to start, and then I can jump in?
Yes, that would be fabulous. Thank you. If you don't mind me removing my daughter from the room first, that would be fantastic. Sorry, I don't think that's the first time that's happened, has it? Apologies, councillors.
No, we love that in real life.
On the data sharing issue, Councillor Culloch, I can definitely reassure you that the processes are very much in place to make sure that the GDPR legislation and everything that we've, I guess, built over the last 10 years around data protection legislation, and the learning from, people may be aware of Care.data, a project about 5 or 6 years ago, which didn't necessarily take those safeguards and didn't continue within the NHS. I think there's been a lot of learning on that. The white paper does have quite a bit on data sharing, and actually puts some real emphasis on social care being able to share its data better within the NHS. And some of the mechanisms will be slightly out of our hands for that, I think, because NHS Digital as a national organisation will lead on better extraction of social care data from council systems. And I'm afraid I probably can't comment on how they plan to do that, but it is within the white paper. But all of it will be within the very closed loop systems that we currently have around data sharing that do try to make sure that consent or another lawful basis for sharing is the key reason for sharing, and data is shared appropriately. One of the Caldecott principles around data sharing is actually that you can actually do harm by not sharing data. I think it's always that delicate balance about what was the opportunity missed when services and projects are not able to happen because data sharing isn't able to be done, and how to do it in a way that maintains the confidentiality and the safety of the data sharing, and make sure the privacy and wishes of people about their own data are respected whilst improving the services that we have. Your first point about the accountability is a very good one, and I think we have to reflect the conversations we have here this evening in the conversations at the Alliance on how we make sure this is an accountable process. Having a reporting line through the Health and Wellbeing Board for this next year, with regular updates, with the minutes of those obviously public, and the meetings webcast, and the discussions about what the Alliance has been working on at the Health and Wellbeing Board, for me, will provide one mechanism by which we do that. And I'm not sure if Councillor Rudsman would also have a comment on that there, but I would see that as a key way that we make sure that this is an accountable piece of work, using the Health and Wellbeing Board's opportunity and the partnerships that we've got around that table to have a degree of accountability for that work.
Thank you, Peter. Councillor Taylor next, please.
Thank you, Chair. Got a fair few questions. I won't do them all in one go. Let other people chip in too. The first question is: so we've got this York Alliance in our place in the Humber Coast and Vale system. Would I be right to assume that the other places in that system are doing the same for their areas, or are we sort of more organised? I'm guessing they're on the case too.
I wonder if Phil is still with us. Phil, do you want to answer that one in terms of Humber Coast and Vale context?
Yeah, I will. Thank you. And then I'll depart shortly. So I'll probably start by saying I commend this to the House. I get there are concerns about it from a number of perspectives. So it's new and different. Where's the accountability? How does it fit with the Health and Wellbeing Board? Which services is it going to focus on? How does it square the money? All of those things are all very valid questions for us to work through. We've got until April 22 before the white paper changes, assuming the white paper passes its readings 1st and 2nd May and June. Assuming that comes to pass, then we've got until April 22 to work through together, and together is the key word here, those questions, issues, and others. Within Humber Coast and Vale, there are 6 places, York being one. The work that we have done probably over the last 4 to 5 months together is considered to be positioning York as an exemplar within the region, possibly more widely across all of the North East and Yorkshire, in terms of how we are working together to create a culture where we put citizens ahead of organisations, and where we start to think about a once-in-a-generation opportunity to co-create and offer for local people that will directly respond in a more bespoke way to the needs of their own families and communities. So not just a citywide approach, but something that is co-created and really bespoke. That in itself is very exciting. The approach that we have taken so far for colleagues who are not as close to the NHS as some of us. So in the past, the NHS has not found it easy to focus on the city. So you've got a clinical commissioning group that is all of the Vale. So Kirby Moorside down to Selby is what we are currently accountable for. You've got an acute provider, York and Scarborough Foundation Trust, with sites in York, Bridlington, Scarborough and others. You've got a mental health provider, Tees Weir Valleys, that has a significant spread of provision. The thing that this does is it brings together organisations within the NHS and across other sectors to focus just on the city. And in doing that, Peter's helping us think about how we create a data set that joins up primary care, acute care, social care, and starts to help us understand the needs of families and people, rather than organisational data sets focusing on organisations and feeding the accountability that they have nationally. So that is a really important change for us. The philosophy that we have adopted in the last 4 to 5 months in getting us this far has been underpinned by one of co-production and dispersed leadership. So all of the documents that you have in your appendix, there are chief executives or senior leaders from different sectors who've taken a lead in producing where we have got to so far. So what we're trying to create is a cultural change where organisations, regardless of the sector that they are from, think about the citizens and families in York ahead of their own statutory responsibilities. So Councillor Cullett's question about accountability is a really good one. if we are to create a once in a generation opportunity here, we've got to transform the way that we hold ourselves accountable for the decisions that we make, so that that is different and better to the way that we've done it before, which has been organisationally dominated. That's quite a step, that's quite an ambition. That's one of the reasons why York is being considered an exemplar, because we have an ambition to move to that way of working in a really transparent way. And that's quite a step to take. But so far, so good. I'm going to commend it to the House and push off. Leave you in Sharon, Peter and Steph's hands, because they are, all three of them, quite ace. Thank you.
Thank you very much, Phil. I appreciate you joining us this evening. Thank you.
One more question, please, Chair.
Sure.
Thank you. And thanks to Phil for that rousing response, and Peter before him. It does feel like we're at the closest point to genuinely joined up working. And I'm very interested to see how this duty to collaborate pans out in reality, because collaboration is becoming one of those heavily used, if not abused, terms in this sector. But fingers crossed it all pans out the right way. But my question is on a different part of the sort of upcoming changes, though. It's about how I believe a chunk of the commissioning the NHS is going to be lifted out of, I think this is called the Public Contract Regulation of 2015. So this is a national change, but it will have local implications for what we're talking about. Are any of the professionals in here able to talk about the opportunities and risks that come with that? I'm assuming opportunities will be more freedom related, but risks, dare I say, could be people bidding for contracts on less desirable terms for its staff, touching on where we were in the previous agenda item, perhaps on increased private involvement. Did anyone speak to that? If not,
have a go. Because I'm ace, obviously. I mean, the devil's going to be in the detail. So what we understand is that traditional open procurement will not be encouraged, and but we will still have contracts. We will have contracts with detailed specifications in them that make explicit about what our expectations are, what the we use this phrase, the financial envelope is, so how much you're going to get for what we want to see. And actually, if I dare use collaboration again, so that we have all of those different professionals coming from the different organisations working on the best solution for local services, that actually, we're not going to get away from addressing ill health, but actually that we really start to live those values about what it means to promote good health. I'm 30 years in, and we've been talking about moving towards population health management, health promotion, whatever terminology you're used to. So that open procurement is something which will be placed to one side, and there's an expectation that the system matures and we hold each other to account. So I don't have the ready answer that talks about how you might move services around to different organisations to deliver whatever we determine is value, but the right health outcome. And it's not just about existing providers. We really want to continue the excellent working with our voluntary sector partners, because that is something which is really paying dividends and has shown some some, you know, really excellent partnering working over the pandemic and before that, but you know, everything's been elevated in this last 12 months. So I think we'll still have contracts, but the that procurement space where we have seen private providers step in, where our existing providers have not wished to offer a service, well, those sort of opportunities become less and less, and actually we start to work as a partnership to actually start talking about how do we want to change the way we deliver services. And we'll have to find a mechanism where we've talked about governance, about and what do you do if a partner doesn't deliver to that specification in a different type of way, and we're waiting for that detail to emerge. Difficult for me to articulate that any fuller when I work in a organisation that will be disestablished. So that's a new word that's coming into our vocabulary.
Appreciate that. Thank you. Is that Paul frozen? Councillor Doughty frozen, sorry. Yeah.
I believe it is, yeah. Does the Vice Chair want to step in?
I'm happy to do what I can. As you realise, I'm not working in ideal circumstances at the moment. But I did have a further question myself, so perhaps if I continue with that, and hopefully Councillor Doughty will rejoin us as I do so. It's really returning to my earlier question, because I think that Sharon Stoltz was about to offer something more on the question of accountability, and also reference was made to Councillor Runciman, who may want to comment on this as well. I'd be very interested to hear what they might have to add.
Yeah, shall I start, and then I'm sure Councillor Runciman will want to say something as well.
Thank you.
Accountability and the governance arrangements around decision making is an area that is going to require further work over this shadow year. I think in terms of accountability within the council, I feel much more confident about accountability within the council, because we've established the Alliance as a subcommittee of the Health and Wellbeing Board. So it will be subject to working within the constitution of the Health and Wellbeing Board. And through the Health and Wellbeing Board, we've then got links into full council, and obviously we've got the opportunity to have these discussions with Scrutiny as well. What isn't so clear, and it won't be for a little while yet, is how the accountability and governance structures between the Alliance and Humber Coast and Vale ICS might work. So what we've agreed with the Alliance is that Phil Metton, as the accountable officer for the CCG currently, has been identified as the key link between York Place and the Alliance and the ICS. But we know that under the white paper, ICS is going to have two boards. One will be a partnership board, so there'll be Humber Coast and Vale ICS partnership that will have local authority representation on it, and then there will be a separate NHS led board for the ICS. what isn't clear yet, and I don't think will be clear until the legislation goes through Parliament and comes out the other end, and we understand a little bit more about how the ICSs will work. It isn't yet completely clear how the York Alliance might be accountable for delegated NHS budgets, for example. So I think you're absolutely right to raise accountability issues, Councillor Killick. We're all aware of them. We're having ongoing discussions about them. And one of the reasons why we were keen to get the Alliance established now is that we have this shadow year to build on and further develop our relationships and work out how those relationships will work, but also having the Alliance established with a foot into the ICS will also be at the centre of some of those conversations as they develop as well. So I fully expect there to be more discussions over the coming months. I think we agreed, Councillor Runciman, that we would be looking at how the Health and Wellbeing Board develops alongside the Alliance and what the relationship between the Health and Wellbeing Board and the Alliance. And then we've made an agreement to take further proposals around that through the Executive and full Council, obviously with this committee as well in the autumn. So there are a number of steps along the way before we get to next April. So I don't know if you want to add anything to that, Councillor Runciman.
Yes, thank you very much. I find this discussion extremely interesting because it's bringing up a lot of questions that have been in my mind as well, and questions that I've asked. I want to just go back a step and say that I've been doing some LGA work with a number of other Health and Wellbeing Board chairs from all sorts of parties about the changes that we're talking about tonight. And I can say without fear of contradiction that the way that people are doing them is not necessarily the same as we are and is different in many places. For some people, the ICS, the local ICS board is actually the Health and Wellbeing Board, which is an interesting idea. And I think that's part of Lincolnshire, but I don't exactly remember which bit. But what I am concerned about is accountability, because as far as I'm concerned, accountability is always to our residents. It's not to a board, it's always to our residents. And although the Health and Wellbeing Board takes accountability very seriously, each organisation is accountable to its own structures, its own governance structures, as well as all of them being accountable to the people of the city. And Sharon is quite right. There's quite a lot of work to be done until we get this sorted out. And for me, it isn't sorted out yet. I want to just add that there's also, you heard Phil say, the regional body is all NHS. The local body has some elected member representation, and people that know will know that I have always insisted that the Health and Wellbeing Board should be representation members from each party. And I can also tell you that's not the case elsewhere. Health and Wellbeing Board I went to visit a while ago, all from the ruling party. The elected members are all from the ruling party. Health is such an important topic. It's got to be multi-party. It can't be single party. And so I think there's a bit of unraveling to do before we get to where I want the new structures to be. And that will be tricky because the accountability in the health service has traditionally been up to the Secretary of State. whereas the accountability for local councillors is absolutely always to our local residents. So I think it's a matter of watch this space, really, but I'm really glad you're looking at it.
Thank you. I think Councillor Doughty has been able to rejoin us, so I hand back to him quite happily.
Thank you very much for taking the chair briefly, Councillor Culloch. I lost the internet connection, I think, here in deepest, darkest Strensall. Actually, while just to add to that, there's a question for Councillor Runciman, actually, if you wouldn't mind, and Sharon might want to dip in as well. With the Alliance being a new subgroup sitting beneath the Health and Wellbeing Board, what groups and structures might there be removed in order for it to function properly or be resourced or avoid duplication? Do we have any idea of that yet, or about changes that might occur?
Well, that's another fascinating question. The last LGA session I was on this topic, I said very clearly to the chair of the LGA that I really felt that if we weren't very careful, we would have the same people on a lot of different boards and they'd all just be recycled. And that wouldn't get us anywhere, because if you're going to the people at the top all the time, it's the same people. And I think that needs to be looked at carefully, very carefully. And the support, of course, as Councillor Doughty says, is always an issue. We're not awash with money in City of York Council, and this board will have to be serviced. You're quite right, and decisions made about when it meets, and eventually when we all, I was going to say leave home, but you know what I mean, where it meets and if there's any cost involved. So that's another little set of questions that need sorting. But the membership is a big issue. You don't want the same people sitting around the table at a whole lot of different meetings, just in different chairs. That really, you want to spread this out so as many people are involved, many appropriate people are as involved as possible, and the public knows who they are.
Thank you.
If I can come in there briefly, Councillor Doughty, with an officer perspective. We are absolutely going to want to look at not just the relationship between the new Alliance and the Health and Wellbeing Board, as I mentioned a few minutes ago, but also our partnership structure. What we've learned through the last year of the pandemic, you know, one of the silver linings of the pandemic is we've learned as a York system to come together, to work collaboratively, to make decisions very quickly, to be able to implement things very quickly. And that's been hugely successful. And, you know, we know that York, in terms of its pandemic response, has done extremely well, and that's across every sector. So we don't want to lose that fleet of foot that we've managed to generate during the last 12 months. And if we look at some of our existing structures, as Councillor Runciman has said, we have lots of different partnership groups. And when you look at the membership of them, it is often the same people turning up at the various groups, and then they all have to be serviced. We want our energies to go into a doing, not to go into just talking about things. So over the next period, and you know, Steph will be aware that these conversations are already starting to happen, will be exactly that. What partnership structures do we need across the city in order to ensure that there's really good engagement, that everybody has a voice and that voice is heard, but doesn't mean you know, taking up lots of our frontline staff or officer capacity. We need to be working very efficiently. And we've all said that, that's the one thing we've learned on the back of the pandemic, is that we can work efficiently when we had to. So we don't want to lose that and go back to old ways of working. But as Councillor Runciman has said, we're only just at the start of that review process, and there'll be further work to do on that, and then proposals to bring forward for consultation.
Thank you, Sharon. We'll go to Councillor Hookness, who's been very, very patient. I think before I lost connection previously, I think you've been indicating, so fire away.
Oh, thank you, Chair. Yes, Shablis, my first point was on GDPR, and Chris, Councillor Kullik preempted me on that one. But one of the things, going back to the last topic, that I think people said they wanted a local GP, because we still hark back to that Dr. Findlay day where the GP knew you and they could see the whole person and not just the symptom that you're presenting with at that time, because then they might realise that that rash is because you're stressed at work, because they know what your job is and all that sort of thing. So although we'll never get to that utopia again, it's nice that you've got all the different organisations all collaborating, so it is a more joint approach and seeing people from several different angles. So that's really wonderful. One of the things, and it was brought on by the diabetes thing, one thing we're really good at now with COVID is screening, because what we're doing all the time, we're testing, we're screening and all that. And to make people better, improve people's health, if you can screen people more and use that knowledge and mass testing and things like that, so that you catch people who've got the problems like the early diabetes or the pre-diabetes and things like that. But if more of that can go on, and I don't know whether you're thinking of that sort of side of it.
I can certainly come in there, Chair, just on the screening thing. One thing that will be happening in York over the next few years, which is very exciting, is around lung health checks. And particularly with my hat on as the chair of the York Tobacco Alliance, the overlap with the lung health check programme, which is being rolled out nationally, and smoking cessation, with smoking being, the cause of 9 in 10 lung cancers and nearly all COPD cases. So that's a programme that aims to deliver CT scanning for high-risk groups, often current and ex-smokers, and do it in communities that are close to where they are, and pick up disease at an early stage, because most people who develop a stage 3 or 4 lung cancer are not likely to live for that long, but a stage 1 or 2 can be treated, and often their life saved. So certainly our plans to develop programs in that way, in line with some of the national screening programs, and a lot of these have to go through a really rigorous evidence base first before they can be rolled out. But certainly there are plans in that regard.
Thank you very much, Peter. Councillor Heaton next, please.
Thanks. Hopefully just a couple of very quick ones from me. I'm just looking, page 17, it's paragraph 9.6. It's just talking there about how the organisation may also be able to retain a set of responsibilities for health locally. I mean, this obviously suggests there's some uncertainties about how we're going to progress. I was just wondering if we could sort of go into those and say what those uncertainties might be, or is it just an over-reading that I'm doing there?
I can happily answer that, Councillor Dati. My sense is that the white paper hasn't yet become legislation, and we have to be careful exactly what we plan for in terms of the occasions where things which appear in policy papers don't then become legislation, or there's things in legislation that didn't appear in the policy paper. So we have to watch a little bit about the precise relationship with the place geography within these proposals, and what level of formality will there be about the funding that goes to place. It could be that these are delegated budgets where the actual money is transferred to a local place area, an organisation with an actual bank account sitting at place level, and that is a model that could be proposed. It could be more that the money is assigned at the regional level into a York Place pot, but sits still at regional level. And there is also North Yorkshire and York as a geographic partnership within this. And those details haven't been clarified in the white paper, and so I think that the terminology about may be able to control is just giving us the flexibility at this stage, because it's not clear within the legislation exactly how the money will be accounted for. At the moment, as I think has already been commented, the Secretary of State assigns a proportion of the NHS budget per head of population to the Vale of York CCG to commission the services that the CCG's commission. That level of formality may be where we end up for York Place, but it's not clear yet.
So just to be clear on that, we're talking largely there about the commissioning budget rather than an operating budget.
Yeah, we are, yes. So the budget that we're talking about there is to commission the services which then providers provide, and the contracts which are currently held with providers. Also, it is not absolutely clear in what form those contracts will change and how they will relate to the new organisations, the ICS on one level, and what is happening at place level yet. And again, it makes this year not only a good year to be in shadow form, so we can have the local conversations, but also so we can be as flexible as possible to differences in the white paper to the legislation, and the other way around.
If
Thanks.
I
And there was
can
just go on, Sharon,
quickly, sorry. Just to say that that's a really interesting conversation, and the outcome of some of the things that Peter will talk about will help direct what form the alliance takes in future, and whether it remains as a subcommittee, the Health and Wellbeing Board, or whether it needs to be established as some sort of legal entity in order to be able to receive budgets delegated to it. So all of those things are in the mix at the moment. It's a very exciting time, but it is going to be quite a lot of work as we work together to put York in the best possible position to be able to receive delegated budgets, perhaps delegated commissioning. We'll need some kind of legal entity to enable us to do that. So that'll be part of the work that we'll be doing over the next months as we develop the alliance.
Cheers, interesting. Yeah, no, and as I say, just the last one from me, and I suspect this will just be very quick. The looking at page 19, and it's paragraph 15 in the bullet points there on priorities. Just a note, I work with NHS trusts around the country, and when you ask them what their priorities are, the first thing that tends to come up is COVID recovery over the next few years. I was just surprised it was a bit lower down the bar there. Is that because we think we're in sort of like stage 2 or 3 of progress, or is there something particular that's seen as a bit lower down?
Well, if I come in there, Councillor Heaton, you're absolutely right. I would suggest for our acute trust colleagues, the thing that keeps their leadership and many of the clinicians and frontline staff up at night is the backlog in the waiting lists, and that is very much part of the support the Alliance wants to bring to the system on that, which will be one of those things that the Alliance has to do. And there will be lots of things that the Alliance needs to do in conjunction with other colleagues, as I think has been suggested. York and Scarborough Hospital Trust covers that geography that is, approximately 60% York residents, but a large proportion of those who are not on the York site, and the Scarborough site is obviously mainly North Yorkshire residents. So the geography means that our acute trusts would probably put that right at the very top. But actually, I don't think the lists within the report were not meant to be a list of priorities in rank order. and I think for us, COVID response and recovery probably frames a large amount of the work that we do, and cross cuts across the work that general practice is doing, that primary care is doing. So I don't think it's meant to be an indication of the priority that we have it. The 3 areas of focus were around specific population groups, because people told us that they wanted us to look at tangible population outcomes and areas where York's health, perhaps going into the pandemic, could have done with some improvement, and we can work on joining up services. And all 3 of those, learning disabilities, complex care and diabetes, have been affected by the pandemic as well. So it all interconnects, I think.
Yeah, certainly. I think when you look down that list as well, you're looking at community mental health, loneliness, self-harm, suicide, addiction. You know, those all filter into COVID elements, won't they? Thank you very much for that.
Sorry, any final questions, members, at all? No, excellent. Okay, thank you very much. I'd just like to thank both Stephanie and Peter for joining us this evening, and for both items, and it's much appreciated. Thank you. You're obviously free to go now. You're welcome to stay with us for the work plan, but by all means, if you want to enjoy the rest of the evening. Thank you. We do have some recommendations actually with this item on page 24. They're really ones to note rather than anything specific for us to do, other than obviously I'm assuming that members will want to agree that future reports are considered by us as time goes on with this. Councillor Taylor?
Thanks, Chair. Sorry I didn't put my blue hand up. It was just instinctive. I think I'm fine with the recommendations, but I wonder if there's any value in us. Could we resolve or try to resolve to at least ask the executive that we could get updates before they do, almost like a pre-decision type exercise? Because the executive's already agreed to what we've got in front of us today. And whilst it's been really interesting and useful, it sort of feels, well, you know what I'm getting at.
Yeah.
There's only so much that could happen as a result of today's conversation, you know?
I agree with you, and we are supposed to be a policy committee. We've still got that in our title. So we should be contributing or having an ability to contribute to it. So I agree with you. Councillor Russman is not with us now, but perhaps if that's a point that Sharon and Louise can just pick up to make sure that, or encourage that to happen, then I'll be certainly supportive of that.
I can. I'll take that forward and see what advice I get back, and I'll let you all know.
Thank you very much.
Okay, no problem.
Thank you. Right, so the work plan. Pages 49 to 52. Now we do have a scrutiny meeting penciled in for the 11th of May, and there are several items on there already, including the update on peer review work, the all-age learning disabilities strategy, and we expect another COVID update by then. What I should say is it's a bit of a moving feast, shall we say, in terms of what might happen with committee meetings and how they'll be going forward, because we're still waiting on LGA guidance and the outcome of a court review, from what I understand, about how meetings can take place. That might affect the number of people on a committee, and whether we continue having them in Zoom or in person. So there are a few things to deal with potentially before that happens. So that's the plan currently. I think we'll probably know more later this month. I think it's late April, the outcome of the court review, I think. I don't know whether Sharon might have more to say on that potentially, but that's my understanding.
Yes. Yes, thank you. We had an update at a meeting earlier this morning from Janie Berry, the monitoring officer for the council. And at the moment, we're still waiting the outcome of the judicial review. The government have indicated that they support the legal action. And that the reason the matter wasn't dealt with earlier is that there wasn't sufficient parliamentary time to be able to make any changes to the COVID legislation, which is why it's ending on the 6th of May under the sunset clause. But until we get that ruling, we're not in a position to be able to make any firm decisions on what will happen with meetings.
Yeah, that's my understanding. Thanks, Sharon, for that. That's the plan for the 11th of May, touch wood, but we'll see that might have to change. I would like to add something to the work plan. I had a discussion with the Director of Operations for York and North Yorkshire for TUV, the Tees Esker Wear Valleys, and that followed, I had this conversation about a fortnight ago now, and it followed some publicity around some CQC inspections. I'll make it clear they weren't in York, but they were in Middlesbrough, Darlington and Scarborough. And there were some recommendations made by the CQC on some work that TUV would have to do to make them compliant, basically, with services. Now, although I've not treated it as urgent because York hasn't been inspected, but there will be some changes, and the director, in all fairness to her, made contact with me to say that there would be some changes required to make them compliant in certain areas. And so what I thought, because we haven't had any item on mental health for some time, and particularly Foss Park having opened when essentially the pandemic had already begun, we've not really had any update reports on Foss Park either, and mental health facilities and services in York in general. So I thought it was an opportunity to ask her to consider coming in the near future, and by that I'm thinking probably one of the summer months, and that's obviously depending on how the meetings fall, and give us a general overview report of update on Foss Park and mental health services in York, but also touch on some of the things the CQC brought up and how that might affect services in York as well. So I hope members would agree that would be something useful to have. So if we can ask Louise if you're all happy with that, just to add that to the list. Obviously we can't pencil in any dates yet because we don't know what's going to happen with the meetings, but just to have it kind of there with thought to discuss at a future session.
Yeah, that's no problem. I can add that.
Okay. Do members have anything else they want to raise at this stage on the work plan? No. Okay. So I think we've said probably as much as we can until we hear the outcome of the judicial review. And I haven't got any further urgent business at all. So thank you very much and enjoy your evening. Thanks a lot.